Hi everyone, it's Jodie from psychosynthesis.online and Opening the Door on Private Practice Facebook group for therapists. So I had a message from someone, and he had seen somewhere or had spoken to someone who had said or read advice that he couldn't or shouldn't take a client who had a mental health care plan. So he's referring to that age-old least favourite topic of mine, Medicare. So should counsellors and psychotherapists take clients on a mental health care plan? No, at one level, because we're not part of the Medicare scheme. So anyone can take a mental health care plan anywhere they like, really, but we don't work under the Medicare scheme. So that's a no for me as far as that goes, because we're not part of that scheme. But firstly, if we're client-centred, clients can go to whoever they like for their treatment. And many clients go to the GP already having someone in mind. What often happens is when they go there, the GP actually then refers them to someone else on his or her list who would never be a counsellor or a psychotherapist, because we're not part of the Better Access Scheme, or the mental health care plan. So we're never ever going to get a look in if you come through a GP route. So I've got many concerns about this, because we know that there's something between PACFA and ACA, something like 10,000 counsellors and psychotherapists who are being underutilised because they're only being referred to psychologists and social workers. And at the moment, there's something like a 3 to 6 month wait list for people. So the fact that we don't get those referrals at some level is utter madness, really. Now, what did I want to say about that? Let me look at my notes, because this is quite a detailed discussion, and I'm not a skilled enough presenter to remember everything I'm going to say. What do I want to say? Yes, a big concern I have is I'm not sure where this don't see mental health care clients, care plan clients comes from anyway. Psychotherapists have actually had more training than psychologists. So we actually train for as long as clinical psychologists do. We do I know in the UK we did a psychiatric placement, so we had to follow a psychiatrist around for a long period of time, and I sat in on group therapy sessions with family therapists, psychiatrists, psychologists, psychotherapists, art therapists. They're a lot more liberal over there than we are here in terms of who they employ, and the subject that was for psychopathology, and a good psychotherapy training, we will, and in fact, most people who have trained in a classic psychotherapy training will absolutely be able to work with the concerns that psychologists work with. We aren't trained, we can diagnose, we're trained in it, but we don't diagnose, and there's a reason for that, because look, some do in the UK, in the US, but certainly my training was a more holistic model where we don't follow the medical model with diagnosis. So we can absolutely see the same level of client that a psychologist can. The next thing. So when the client goes to the GP, they may be suffering with depression or with a sense of loss. They may have an eating disorder. If we were only to see the psychologist or the social worker for that, whoever that's being referred to, that person's being referred to, this is ridiculous. I have worked with eating disorders for 40 years. I've been living with eating disorders and lived experience and then training, but working with eating disorders for 20 years. So Medicare and mental health care plan people will get 40 sessions a year on Medicare. So they will get to see a psychologist under the Medicare scheme. That doesn't mean that I shouldn't be working with that client. In many ways, I've had a lot more experience. Someone with a years of experience could be referred to with that client. So come to grief and loss, for example. My dear colleague, Kate Wotherspoon, who I just love, I think she's the best grief and loss therapist in Australia. She would never be referred to on the mental health care plan because she's not part of that scheme. That doesn't mean she shouldn't be referred to. She won't be. I mean, I think she does actually get GP referrals now because they know how fantastic she is. But if someone came to her with a mental health care plan, absolutely she should still work with them if it's a grief and loss concern. What else here? When we're talking about depression, GPs are often, one of my clients was a GP. She said they get minimal training in mental health concerns. We are actually better qualified to decide whether someone needs to be referred on or not in many ways. And I'm not saying that GPs can't do that, but we spend our whole degrees talking about mental health, not just one weekend here or there. So we're very skilled at knowing when to refer on. Coming back to the depression, that was it. Depression, sometimes I think right intention, wrong intervention. So this time last year, we were in the Sydney lockdown. I had a deep existential depression. If I had gone to the GP, I would have been diagnosed probably with depression, maybe suggested to have some medication, go along with some CBT, 1, 2, 3. That is not what I needed. I needed exactly what luckily I'm a psychospiritual psychotherapist, so I knew that I was suffering an existential depression and a dark night of the soul. I went and sat in the dark woods. Now, I didn't just do that. I went and, I'd already had a therapist. I was seeing a somatic psychospiritual psychotherapist. I was doing my nature therapy training, so I was using that as a holding container. None of these things involved change your thinking, take medication or anything like that. If I had gone to the GP, I would have been diagnosed with something, and it would have been incorrect. So I think we need to be careful around, and actually there's a website called MAD in America, and they talk about the pathologization of everyday concerns. Now, I'm not saying an eating disorder is an everyday concern. Of course not. It is a very, very, very serious illness. But there is more than one way of working with eating disorders, and the medical model is just one way. Likewise with depression, anxiety, and whatever else. What else? Okay, yes, about GPs. We need to remember too, and I was going to say about GPs, but I've already said it. We need to remember too, and I've mentioned this before, people are only attending between 1 and 3 of their Medicare sessions. Why is that? It's interesting, isn't it? I mean, why are they only attending between 1 and 3 of their 6, 10 or 40 sessions? I don't understand that. I have my suspicions, but I need to fill that out a bit before I do a whole episode on that. So maybe this route isn't best for everyone. Maybe. Who knows? Okay. I think whoever is saying this is gatekeeping mental health care. I really do. It's very masculine orientated. It's very medical model orientated. The GP knows best. Obviously there is probably as many female GPs these days as male, but it just feels very white, middle class, masculine. Yeah, I don't know. I don't know where this is coming from, that we shouldn't see these clients. However, well, first of all, it tells me that the person probably isn't trained properly in counselling or psychotherapy, that they don't have that background, and they're not aware of how skilled we are as professions, because there are some very, very, very skilled counsellors and psychotherapists out there, very skilled. Okay. However, as a duty of care, counsellors and psychotherapists, we need to make sure that we are doing really robust assessments with people on the telephone and in that first session. So on the telephone, if someone's rung up with a mental health care plan, I'd be curious to know for what, and what are they calling for? Why have you chosen me to call? And of course, I would tell them that I'm not under the Medicare scheme, and I don't take that. But to continue a conversation with that person is not unethical in any way, shape or form. The person has called me because something has spoken to them. Now, if I don't know, if I am not the right, if I don't believe I'm the right therapist for that person, of course I'm going to refer that person on. I've referred many times to clinical psychologists and psychiatrists, to even a social worker, to whatever that person needs. The majority of counsellors and psychotherapists know what their limitations are and how to refer on to someone. And as long as they are very, very clear that we are not part of that scheme, but would you like to have a chat anyway about whether I can help you or not, there is nothing wrong with that. They've reached out for a reason. And when I ask people, they say it's because of what you wrote about this. It was because of your lived experience. Or I used the plan, or I wanted to go to the plan, but I didn't like the look of the person I was being referred to. I keep coming back to your website. I'm not then going to say, sorry, I'm not going to work with you because you've got a mental health care plan. That's, I think that's gatekeeping people's mental health. So what to do? Yes, you definitely need to tell them, I am not part of this system. Can I help you in some other way? And you have your normal chat like you would have with a normal client. What else have I got here? Yeah. I don't work privately under the mental health care center. Here's my website information. Here's my fees. This is how I work. There is no, I'm not coercing anyone to do anything. I have got another video, how to convince someone if they've come with Medicare or something like that. I'll post the link to that. Hint, hint, we don't convince anyone, but we're allowed to talk to them and say, these are my services. Would you like to book in for an initial appointment, or let's have a chat on the phone, or whatever. As long as you are being upfront that we are not part of that system, there is nothing unethical about that. What I would be looking out for, though, if, for example, someone has been, maybe they're, quite often people will say to me, oh, I've got borderline personality disorder. And I think, oh, have you? Because we don't diagnose in psychotherapy a lot of the time. And we see that borderline presentations have often had trauma histories, and it's often a response to a interpersonal trauma history. So, but I'm thinking, does this person, I would be thinking, I work with people with borderline issues. I work with people with eating disorders. So that's the majority of the clients that I work with. There's often borderline presentations in there. But can you work with that? Can you work with the underlying trauma associated with borderline personality disorder? That is what you really need to be looking out for if someone's come with a plan. And if you don't, then you don't think, oh, I'll wing this. You think, actually, I need to make sure that this person goes back and gets the care that they need. Yeah, I think that's all. Let me have a little look. Yes, I think that's all I wanted to say. Okay. In terms of building a thriving Medicare system, fumbling my words, in terms of building a thriving Medicare-free practice, I have something exciting to share. It's called TheraBundle, and I'm going to put the link, and it's about $3,000 worth of amazing products and courses and things that you can use to help build your practice. So you don't need to worry about Medicare. Medicare. You don't need to worry about that. Okay, I hope that's useful. Bye.